What's up, everybody? It's Rad Tech Week. Again, to y'all, happy Rad Tech Week, and everybody else. All right, so we are doing T-spine today. We have our patient who fell. I think of a good, fun injury that she had. She was trick-or-treating, she was downtown, partying too much, not taking care of her kids. No. Somebody pushed her, she fell down, and now she's here in the clinic today. So, what's the first thing we need to do? So when we are using the table, a lot of things move, right? This moves. This down here moves, right? What else moves? The table moves. So, what do I want you to move when we're positioning the patient? All of those?
No.
No? What do I want you to move? Or what don't I want you to move? You get these lined up. Don't touch them. We'll come after you, people. We'll come up behind you. No, I'm not going to smack him right in the back of the head. I may think about it, but I won't do it. So get them lined up. Make sure that you are detented. The other day we were off. Nobody realized it. Like, oh no, that's why it looks like that. Yeah. So gotta check our detent. We gotta check all those things. Does anybody know the size of this image receptor?
14.
Trying to see if it actually said anywhere on it. It doesn't. It is 14 by 17. So, which way is the spine longer, across or up and down?
Up and down.
Up and down, right? So we want our image receptor placed that way. Now, when y'all were watching Susan, or that's what we call the Rad Tech Bootcamp lady, where did she say to place the image receptor for the AP?
2 inches above
2 inches above who?
shoulder.
2 inches above the level of the shoulders. Why way up here? Why would we do that?
A little bit.
So we don't clip the anatomy. Simple question, guys. Wasn't that difficult? Don't be afraid to talk. So, lined up. And I had to move this because she's a little high up on the table. She didn't lay in the middle, she lay way up there. And that's okay. Because patients will rarely do exactly what you want them to do when they walk into your department. Pretty rare that that's going to happen. Now, do I recommend, as a male, I reach in and start palpating and finding her jugular notch?
No.
Probably not the best idea. What's another way I could do it? Is every patient going to know where their jugular notch is?
No.
Probably not. So, one thing, having this IR 1.5 or 2 inches above the shoulders is going to let me know that more than likely I'm going to catch all of that spine. If I had someone who was 7 foot tall on the table, different story. Never x-rayed anyone that tall. I can imagine though that it would be a little more difficult. You might have to do it in 2 sections. So I'm going to keep that up here, lined up. Now I'm not going to mess with those anymore. When I do, y'all can yell at me. Well, maybe not yell, but I have something in my finger. It keeps hurting. Our collimation. What's our SID again?
40.
40. So our collimation on here should be no more than 17 inches long, right? Why 17 again?
Because that's how big the.
That's the image receptor size. Do we need all 14 inches side to side? No, the spine is not that big. 5 or 6 is plenty. So I am at, so remember, we follow the 40 around till we get to 17, which is right there. So what I can do also is I can palpate the, what's this called again back here? What's that C7 called again? Vertebral prominence. So I can find that and measure that level, and then I'm going to go about 5 or 6 inches below that, 6 or 7 maybe. So I'm pretty happy where I am. Other thing I need to check is my patient straight on the table? I've told y'all, don't stand on one side. You can't just stand here and look, because from right here, she might look straight. I get down here, she scooted this far too much. Again, am I going to tell my patient scoot a little bit this way or that way? I normally don't, because I know they're not going to. In males, this is where we have to be careful. We don't just want to grab the patient and move them. So I try to scoot over just a little bit. Iris is really trying hard to be nice and straight. She's got her toes pointed up. She's got her hands flat. She's doing everything else I would like. So a lot of it is just fine tuning, walking around the patient. It's kind of like when you're buying a new car. You walk all around it, kick the tires a little, make sure it's good. We don't want to kick our patients, see if they're good, but you'll get what I'm saying, right? All right, what does the book say is our breathing instructions here?
Orthostatic.
Sorry?
Orthostatic.
For the AP.
Should be not.
Sorry?
Should be not in motion.
So we're going to have the patient take a deep breath in and hold it. Okay, deep breath in and hold. Why do we think we want to do it on inspiration? What moves when we breathe in and out? Diaphragm. So we want to push it down a little bit. When we breathe in, it goes down, so we get it out of the way of that thoracic spine. We also need to mark our image, the correct side. Not like on last week's video where I marked the wrong side. And trust me, a lot of my viewers pointed that out. I'm like, yeah, y'all got me. If you watched the whole video, you would see where I realized it. So this is her right side. So I can probably just do that, right? Some techs do that. You work with people, you've done that? I've never once put a marker on a patient. It makes me nervous. So in this case, I'm going to put it on the image receptor. So I think of where the midline is. We have these little notches, right? I don't want to put it right there because that's where the spine should project. So I'm going to move it out about 3 inches. That's going to be out of the way of the spine. I know it's going to come out on the image now. All right. Patient, take a deep breath in and hold it. Didn't see the patient breathe. Not sure, so I'm going to hope that they did. Take the exposure. What do I need to tell the patient now?
She can breathe.
Breathe again. That way they don't pass out. That's your AP. Okay? Are we going to see all 12 thoracic vertebrae here?
Yes.
That's in the AP. Look, just think. It's right here. We're going to see them all. We're going to see C7, maybe C6, depending on where we are. Lateral is going to be a different story. All right, so we're going to have you roll to your left side for me, please, ma'am. Now, I had the right marker, so I'm going to take that one off because I had her turn to her left side. All right, so we're going to bend your knees. We're going to put your hands together like you're clapping. You can go ahead and lay your head on the pillow here. All right, so, excuse me. So a lot of this is making sure your patient is lined up straight. So right now I can tell that this shoulder is a little more in. They're also way offset. So what I do is I'll either push that shoulder in, or if I need to pull it back. The other reason I have the elbows there, I can get the elbow and I can move her back. So I can control her like that. If I need to roll her forward or backwards, I usually tell men this, hammer fists. That way I'm not grabbing the patient like this. So from here, I can roll her forward or back however I need. And it's not as intrusive feeling as if I was doing this, right? Yeah, so we have to make our patients comfortable. We don't want to be creepy or weird, guys. And yes, ladies can be creepy and weird too, but let's be honest, for the most part, it's guys. Don't be that guy. You want to hand me the glove, Julio? Do my Michael Jackson impersonation real quick. So remember, we are going to lay this behind the patient to do what? Catch it. Catch any backscatter. Any scatter coming off the back of the patient. And yes, if the patient requires it or requests it, we can lay a shield over the waist. Don't get me started with shielding again today, guys. I use the back of my hand to see if the patient's straight. I'm not gonna do this because again, it's gonna feel awkward, so I'm gonna use the back of my hand. And to me, it's easier. Everything's nice and stacked, hips, knees, feet, shoulders, all on top of each other. I should not have to change my central ray location very much. We have a little bit of light posterior, which lets me know that I am going to capture all the spinous processes. I'm not going to clip any of them. These things also shed a bunch of the fake leather that's on them. So she's on her left side, right? So I could put a left marker back here. That would be correct because it's the left side. If I wanted to have the marker anterior, I could lay it in front of her, but I know it's not going to come out. So what I'm going to do again is I'm going to leave it on the image receptor, place it away from that center line. That way I know it's not going to obscure anatomy in this lateral projection. Check again, make sure your patient's nice and straight. Your SID is set at 40. Collimation is no more than 14 by 17. For this one, ma'am, you're gonna hear the machine make a lot of noise because it's gonna take a longer exposure. So I want you to breathe normally, okay? Have the patient breathe normal. How long do we want this exposure to last? 3 to 4 seconds. And why? What's the purpose of that again? Blur out the ribs. Orthostatic breathing. Remember that term. Okay? Questions?
Is it okay to like crop the front?
Yes. Yeah, if you look right now, I don't have any light past right here.
As far as
Yeah. What body plane am I kind of lined up with? Coronal. Exactly. We're lined up with that coronal plane. All right, guys, that is your AP and lateral T-spines in a nutshell. Thank y'all for watching.